Are you really immobilizing that limb? Or are you just throwing cardboard tape and Kerlix at the patient until they surrender? Let's make your next splint Eagle Scout perfect on this episode of One for the Road. Splinting is an essential component of most scenes involving isolated limb injuries. But let's face it, some of our splints end up looking extraordinarily good, and some of them end up looking extraordinarily bad. And the worst of them don't even accomplish what the primary goal is, which is immobilizing the limb inside the splint. There's many reasons why a splint can go wrong. Too many cooks in the kitchen, not enough padding, using a dusty old hunk of cardboard instead of some type of professional splint, maybe a lack of practice or a lack of experience. But here's a few things to help you and your next patient that needs a limb splint. The first thing I want to say is when we're splinting a patient, I feel like we should just put one person in charge of the splint, technique and all. Let somebody be in charge. That doesn't mean that they have to do all of the things involved in splinting, but they should definitely direct the team. When we have too many people giving advice and input and physical help with the splint, it tends to go worse than if we just follow one person's vision for how to make that splint perfect. Another is remember the ice pack, right? Ice packs are important. Sometimes we lean heavily on pharmacologic pain control, and we forget that ice packs do reduce swelling and they also reduce pain. And we can put them inside the splint. As long as we protect the patient's skin from the ice pack, that ice pack shouldn't be in direct contact with the patient, but they can be very helpful inside of a splint at reducing swelling and pain. I also feel like if it's available to you, you should use a conforming splint, like a vacuum splint, whenever possible, to form it around that limb instead of something straight that isn't shaped like the patient's limb. I also believe that triangular bandages are our friend. We overuse Kerlix and we underuse the triangular bandage when we're splinting a limb. When we have the physical limb splinted, we're not done yet. Triangular bandages are great for bringing that limb against the patient and allowing them to rest that splint in that limb so they don't have to keep holding it up. Another one I want to throw out is don't forget to repeat that sensory assessment. That's important. It's important that we do a sensory assessment early on, and most of us remember that, but it's also important to do that sensory assessment after we've completed splinting that limb, and we don't always remember that. Lastly, I want to say know when it's time to go. Not every patient is appropriate for us to spend time on scene doing a detailed limb splint. If a patient is hemodynamically unstable, if we're not talking about an isolated limb injury, then we should either splint en route or possibly not at all. However, that's not an excuse to not splint patients. Patients who have isolated limb injuries, who are hemodynamically stable, we should take the time to do a good job. Those patients should not arrive at the emergency room holding their own limb if we had time and availability to splint that limb correctly. So that's it. You don't have to be an origami master to make a good, effective splint. Pick a person to be in charge. Have a plan. Consider one of those EvacuSplint type vacuum splinting devices. Use ice packs liberally. Don't forget those triangular bandages. Repeat that sensory assessment and know when it's time to go. That's my list. But wait a minute, there's something you're thinking in your head right now, like, oh, I can't believe he forgot my best splinting trick, right? Go down to the comments right now before you click away. Let us know what is your essential go-to limb splinting trick. And then we can all learn from you too. I'm Steve Whitehead. I appreciate you watching. That was One for the Road.